Good morning, children. Today we shall be covering the epidemiology, prevention and control of influenza. Influenza has been a cause of concern all over the world because of its capability to incite pandemics and epidemics. Spanish flu of 1918 killed approximately millions of people and infected few millions all over the Europe. Asian flu in 1957 spread over all the Asian countries, including the Indian subcontinent, and killed millions and millions of people. Similarly, in 1997, there was Hong Kong flu. It killed many people in the Hong Kong and Singapore area. And last but not the least, in 2009, the pandemic, what happened in Mexico, it covered the American and the Canadian subcontinent. At present, an epidemic of influenza is going on in US since October 2019. And that has caused 26 million cases and also approximately 16,000 deaths. Influenza is commonly referred as flu, a viral infectious disease caused by RNA virus. It affects the birds and the mammals also. The common symptoms are chill, fever, sore throat, muscle pain, severe headache, coughing, fatigue, and general discomfort. Although mistaken for other influenza-like illness, especially the common cold, however, the symptoms and signs in influenza is always severe. WHO defines influenza a viral infectious disease that affects nose, throat, and the tracheobronchial mucosa, usually lasts for a week and characterized by sudden onset high fever, aching muscles, headache, severe malaise, non-productive cough, sore throat, and the rhinitis. The sequence shows the timeline of influenza outbreaks all over the world. I have already discussed the Spanish flu that happened in 1918, killed approximately 50 million people. And thereafter, somewhere in 1933, Smith-Wilson found out the genetic configuration of the influenza virus as H1N1. In 1957, this genome of the virus changed to H2N2, and thereafter there was a pandemic, and this is known as the Asian pandemic. Somewhere in 1997, there was Hong Kong pandemic, and 2009, the Mexico pandemic. The epidemiological determinant of the influenza virus is that it is classified within the orthomyxoviridae group. It has got three subtypes, A, B, and C. Three viruses are antigenically distinct and different, and there is no cross immunity. Influenza A and B virus is capable of causing epidemics, whereas influenza A causes even pandemics. Influenza A and B virus have the distinct surface antigens. These are the glycoproteins, and they are known as the hemagglutinin and the neuraminidase. Hemagglutinin is responsible for attaching the virus to the host cell, whereas neuraminidase causes the release of the virus after multiplication. Influenza A virus is unique in antigenic. Sudden, complete, and major change in the viral genetic configuration can take place, and that is known as the antigenic shift, whereas there could be a gradual change over a period of time, which is often called the antigenic drift. Antigenic shift results from the genetic recombination of the human virus with the animal and the avian virus. And there is a genetic reassortment, whereas either the H antigen changes or the N antigen changes or both change. It can cause major epidemics and pandemics involving most or all the age groups. Antigenic drift involves point mutation in the gene owing to the effect of the herd immunity of the host population. Antigenic changes occur to a lesser degree in the subtype B influenza virus, whereas antigenic changes never occur in the influenza C type virus. Since the isolation of the virus in 1933, there has been two changes. The first change occurred in 1957, where the viral genetic factors changed into H2N2, and in 1968 it changed into H3N2. The strain prevailing between 1946 to 1957 were H1N1, and there was a shift in 1968, only the H antigen. Again in 1977, a new strain of the virus, that is actually the preliminary strain, that is the H1N1, reappeared in China and USSR. And it did not displace the H3N2 prevailing virus at that time. The reappearance of H1N1 in 1977 did not displace the prevailing H3N2, and dual infection continued. So as of now, there are two antigenic varieties of the influenza A. The first one is H1N1, the second one is H3N2, and together with influenza type B is also present and prevailing in the community. Influenza viruses of H1N1 subtype caused epidemics in the two periods of 20th century. The first one was from 1946 till 1957, and thereafter again from 1977 till date. The epidemic which is going on in USA is at present involving H1N1, H3N2 and type B influenza virus. The sequence shows the structure of the virus. You can see that the viral genome consists of RNA. These RNAs are segmented RNAs, and it facilitates the genetic recombination, mutation and reassortment. There are certain antigenic tabs on the surface of the virus. The red-headed ones are the hemagglutinin, and the white-headed ones are the neuraminidase. Hemagglutinin is responsible for attachment of the virus to the host cell, whereas neuraminidase is responsible for release of the virus after multiplication inside the host cell. There are certain viral proteins, they are called nucleoproteins as well as the capsid proteins. Depending on the nucleoprotein and the capsid protein, the virus is subdivided into two groups, that is three groups, that is A, B and C. There are approximately 17 subtypes of hemagglutinin antigen and 10 subtypes of neuraminidase antigen, and they are coded as H1 till H17 and N1 till N10, and by combination permutation there could be 16 antigenic subtypes of the influenza A virus. The virus has a variety of reservoir. It can be hosted by mammals, by humans and by the birds. Influenza virus has been found in the swine, in horses, in dogs, in cats, in the domestic poultry and also in the wild birds. The animal reservoir provides new strains of the influenza virus by combining with the human viruses by recombination and reassortment of the genetic configuration. The source of infection is mainly a case or a subclinical case. During the epidemics, large number of mild asymptomatic subclinical cases occur, which helps in spreading the infection. Secretion of the respiratory tract and the nasopharyngeal secretions are infective. It is an aerosol droplet infection, Infectivity starts couple of days before to couple of days after the onset of the symptoms. Incubation period is generally 18 to 72 hours. Influenza virus doesn't show any affinity to particular age and sex. It affects all ages and both sexes. In general, the attack rate is lower in the adults and higher in the children. Highest mortality during epidemic occur in the high-risk groups. The high-risk groups are people aged 65 years and above, infants below 18 months, and diabetics, patient of chronic heart disease, kidney disease, and the respiratory ailments. Human mobility also help in spreading the infection. The virus, once it attacks a person, the immunity is developed within the human system. This antibody appears within 7 days after the infection, and its level goes up to the maximum within 2 weeks. After 8 to 12 months, however, the antibody level drops down to pre-infection standard. Antibody to H antigen neutralizes the virus, whereas antibody to N antigen modifies the course of infection. IgG antibodies develop in the respiratory tract, and antibodies must be in sufficient quantity in the respiratory tract to prevent invasion by the virus. There are certain environmental factors which favors the influenza spread. Some seasonal factors include the winter months in the northern hemisphere and the summer and the spring in India. Overcrowding is another contributory factor. Attack rate is high in the closed groups like the schools, institutions, and the ships. Pathogenesis for influenza virus in the human system is very simple. The virus enters the respiratory tract, causes inflammation of the superficial epithelium of the tracheobronchial tree, and thereafter it brings in secondary bacterial infection. However, there is no systemic viremia. The signs and symptoms appear within 1 to 4 days. There can be sudden onset of fever, high-grade fever ranging from 101 degree Fahrenheit to 103 degree Fahrenheit with chill. There can be sore throat, dry cough, fatigue, malaise, severe muscle aches, diarrhea, and dizziness. Both the viruses cause the same kind of symptoms. If the fever lasts for longer time, there is a chance that the person is developing pneumonia. Pneumonia is one of the commonest complications of influenza, and it is the cause of mortality and fatality approximately in 3% cases of influenza. It is said by recurrence or the persistence of the fever. There is another complication in the children which is very uncommon, maybe 1 in million, is known as the Ray's syndrome. It is characterized by nitrogenous hepatic encephalopathy. There is a difference between the common cold, which is often known as the ILI or the influenza-like illness, along with the actually when compared to the influenza. Certain symptoms like the fever, headache, fatigue, extreme exhaustion, chest discomfort, and the respiratory distress are more severe in case of the influenza, whereas it is generally less in common cold. The diagnosis of influenza is generally either by isolation and identification of the virus from the nasopharyngeal secretions or by the paired sera test. The nasopharyngeal secretion is the best specimen for obtaining the virus infected cells. The virus can be detected by indirect fluorescent antibody technique. However, egg inoculation is also required to be done for isolating the virus as well as antigenic analysis of the virus. Paired sera test is a special test which is done in case of influenza virus diagnosis. 2 serum specimens are taken The first one taken as early in the infective stage, not later than 5th day of the infection, and the other one in the convalescent stage, approximately 10 to 14 days after the onset of the symptoms. The titer of influenza antibodies are measured, and if there is a 4-fold rise in the titer, that is considered as the diagnostic of infection. The diagnostic labs for influenza are available in India. There are approximately 6 renowned seminal labs, out of which the School of Tropical Medicine, Kolkata, is one of them. However, more surveillance centers and more sentinel labs are initiated and organized during any impending epidemic. There is a rapid test for influenza where direct-antigen flu and direct-antigen flu A and direct-antigen flu A plus B are used for rapid diagnosis of the influenza virus, and here the test results are available generally within 24 hours. Antiviral drugs are available for treating the influenza. The drugs like amantadine and rimantadine can be used for influenza type A virus. There are certain drugs like zanamivir and oseltamivir which can be used against both the influenza A and influenza B viruses. The oseltamivir is known as the Tamiflu, commonly marketed in the dose of 75 mg, 60 mg and 30 mg tablets or the capsules. Adult dose for the oseltamivir is 75 mg BD for 5 days. It is a therapeutic dose. The same 75 mg once a day for 10 days can be given in suspected cases to prevent the invasion of influenza virus. So this is a prophylactic dose. For children and infants below 3 years, the dose is 3 mg per kg of the body weight. Prevention of influenza includes the use of vaccines. Annual vaccination program should start 2 weeks before the expected season of influenza. The vaccine should contain the prevailing strains of the influenza as well as the strains of the previous seasons. The new vaccines that contains different influenza virus need to be developed, therefore, each year. The vaccine is generally trivalent. It generally has the 3 components H1N1, H3N2 of type A influenza as well as the type B influenza antigens. Vaccines are indicated for essential public servants like the healthcare personnel, the doctors, the fire services personnel, the police and similar essential public servants. Old age group and the people with chronic diseases like those who are suffering from diabetes, those who are having respiratory ailments or the kidney diseases. There are 2 kinds of vaccines, killed vaccine and the live attenuated vaccine. The killed vaccine contains H antigen of 15 microgram per dose. The dose is 0.5 ml subcutaneous for the adults, and for children below 3 years the dose is 0.25 milliliter subcutaneous. The protection rate is approximately 70 to 90%. Immunity lasts for 6 to 12 months. The common complications are local inflammation, pain, fever and a very atypical syndrome called Guillain-Barré syndrome, in which there is ascending motor neuron paralysis. However, it is very uncommon. It happens 1 in 10 million cases of killed vaccinees. The live attenuated vaccine is also a trivalent vaccine. It contains A H1N1, A H3N2 as well as the influenza type B virus. It is used as nasal spray. Protection rate is 60 to 70%. It is not recommended for immunocompromised patients. Finally, we come to the conclusion that it is very important that influenza epidemics and pandemics have caused enormous losses to the mankind. Antigenic heterogeneity makes it difficult to introduce standard universal vaccine for all seasons. Current US epidemic has caused 29 million cases and 16,000 deaths. Available vaccines are only 60% effective. Medical treatment, although available, but it may not reach the poor. The poor may not be able to access the medical treatment with the costly medicines. Influenza therefore remains an unresolved recurrent challenge for the medical fraternity. At the end, I give you some assignments. There is a long question. Write the infective epidemiology of influenza in the background of agent, host, and environment. You must write in detail about the infective agent, that is the influenza virus. It's a 6 marks question. Write short note on antigenic heterogeneity of influenza virus, commonly used antiviral medicines for the influenza virus and influenza vaccine. And there are certain fill in the blanks. We expect you to answer these questions and send it back to us within 3 days for evaluation. Thank you.